Hi, everyone. Welcome to today's Student-Led Journal Club. My name is Anne-Marie Hayes, and I'm a research associate on the Joplin campus of KCU. Today, I will be introducing our speaker, student Dr. Morgan McBride. Today, they're going to be talking about their cadaveric study as they're an anatomy fellow, and you're about to hear. So without further ado, let's get started. Student Dr. McBride is currently an anatomy fellow in between their second and third year on the Kansas City campus. They completed their undergraduate education at Missouri Southern State University in Joplin and received their Master of Biomedical Science at KCU. They are currently interested in surgery, but are looking forward to experiencing all the different specialties during rotations this year. In her spare time, she plays sand and indoor volleyball with her boyfriend and enjoys spending time with their family and dog, Cube. So without further ado, the floor is yours, student Dr. McBride.
Thank you. So as Anne-Marie said, my name is Morgan McBride. I'm an anatomy fellow here on the Kansas City campus, and today I'm going to be talking about my project, Anatomical Interaction of the Greater Occipital Nerve and the Obliquus Capitis Inferior. So I'm going to start off just talking about the basic anatomy of this project. So my project had to do with the greater occipital nerve, and this nerve arises from the dorsal rami of the C2 and exits between the C1 and C2 vertebrae. It's then going to travel underneath the muscle we're interested in, the obliquus capitis inferior, in a J or hook-like trajectory. It's going to provide innervation to the scalp behind the ear. And then the muscle we're interested in is the obliquus capitis inferior, and this is going to originate on the spinous process of the C2 vertebrae and insert on the transverse process of C1. And this is responsible for ipsilateral rotation of the head. So in order to get to these, we had to remove a few muscles. So we had to remove our semispinalis capitis as well as our splenius capitis, longissimus capitis, and then to make it easier to visualize, we also removed our rectus capitis posterior major. And then here's just another view showing this muscles with the nerves. So this is the nerve of interest, our greater occipital nerve, and then this is the muscles that we had to remove. And this is our obliquus capitis inferior, where you can see the greater occipital nerve creating that hook-like trajectory underneath it. And this is what we were actually dealing with. So here we have our spinous process of C2. Over here is our obliquus capitis inferior muscle, and it's inserting over here on the transverse process of C1. And what we have here is our greater occipital nerve. And then the same thing on this side, just a little bit closer up in a different body. So here's our C2 process. Here is our greater occipital nerve, and then our transverse process of C1 is a little bit more difficult to see in this one. So why is this important? So I was looking at this interaction in relevance to possible headaches. There's a lot of different kinds of headaches, so I was just going to kind of stick with the basic ones. So first off, we have primary headaches, and most people probably have heard of these. We have migraines and tension type. Those are the two biggest in this category. Then we also have a category of secondary headaches, and there's a lot that falls under this. This is a headache that's caused by another disorder, infection, injury, or exposure. And in particular, I'm going to focus on the persistent headache attributed to whiplash injury. And then the last category is cranial and facial neuropathies. And again, there's a lot that falls under this, but we're going to focus on occipital neuralgia. So like I said, my project's more focused on persistent headache attributed to whiplash and occipital neuralgia, but I do want to point out the importance of the greater occipital nerve's role in primary headaches as well. There was a study performed in 2022 that found the greater occipital nerve block significantly decreased the amount of analgesics a patient needed, as well as the number of monthly attacks in patients with migraine and tension type headache. They're not typically thought to be due to greater occipital nerve irritation, but the greater occipital nerve converges in the trigeminal pathway in the nucleus caudalis, and that's kind of thought to be believed to be why this has good success in patients with migraine and tension type headache. Now going back to this persistent headache attributed to whiplash. So this is a headache that develops within 7 days after a whiplash injury and lasts about 3 months or more. So if you think about the anatomy, this nerve's coming out between the C1 and C2 vertebrae, and then it's traveling underneath the obliquus capitis inferior, where it's then going to pierce the semispinalis capitis, which was one of those muscles we removed, as well as the aponeurosis of the trapezius, and then it travels to the scalp. So the obliquus capitis inferior muscle is immobile during flexion and extension, so it kind of acts as like a pivot point for this nerve. So if we exceed physiologic motion, which happens in whiplash with that flexion and extension, it's possible that this nerve could be irritated due to the sudden stretching around this muscle, particularly in flexion. And then the last one, occipital neuralgia. So if you don't know what this is already, this is a pain that is recurring. It's very severe. It's like a shooting, stabbing quality in the distribution of the greater occipital nerve, as well as the least and third occipital nerve. This pain has to be associated with dysesthesia and allodynia of the scalp, as well as one or more of the following, this is the important part with this project. So to diagnose this, the pain is eased by a local anesthetic block, which happens to be the greater occipital nerve that they use. You also have to have pain and tenderness over the greater occipital nerve or the C2 distribution. So like I said, greater occipital nerve block is used to help diagnose this. So it's therapeutic as well as diagnostic. Usually an anesthetic along with a glucocorticoid is given in this. And there was a study of 44 patients given lidocaine or bupivacaine, as well as dexamethasone, and this had a 95% success rate in treating these patients. Bilateral occipital nerve block can also be used in adjunct with pharmacotherapy for migraine treatments. And then I found a really interesting case that goes perfect with this study, and I just had to share this one. There was a case of a patient who had intractable occipital neuralgia, and his physician suspected it was caused by entrapment within this obliquus capitis inferior muscle. So the patient underwent obliquus capitis inferior muscle injection rather than the nerve. So they used the local anesthetic and the glucocorticoid, and it had favorable results. The patient had originally rated his pain a 9 out of 10 to a 10 out of 10. And after this injection of the muscle, it brought it down to a 1 to 2 out of 10. So due to these good results, they ended up doing a greater occipital neurectomy as well as an obliquus capitis inferior partial resection. And the patient had really good results after that. To my knowledge, there's not a lot of research out there about the obliquus capitis inferior and greater occipital nerve interaction. And just based on, even though this is just one patient, there could be more patients out there. So I think that kind of opens up a door for more options for research. So the goals with my project. So I wanted to gather the frequency of attachment strength of this nerve to the fascia of the muscle. This was inspired by a study done in 2019. Dr. Shearer and their colleagues were looking into the fascial attachment strength of the greater occipital nerve to this muscle and the possibility to entrapment. The goal of their study with this was to gain a better understanding of the anatomical relationship to this nerve and muscle, and to help treat and understand post-traumatic headache attributed to whiplash. So my goals are similar to theirs, except I wanted to gather a little bit more information about the interaction between this nerve and muscle. So I'm going to categorize, or I did categorize, the nerve into 3 different categories of loose, tight, or embedded. And I'll go into like how I picked that out and kind of describe that in a little bit. And then I test the actual strength of the nerve to detach it from the muscle. And then the last thing we're going to do, which unfortunately isn't quite done yet, we're going to examine the nerve histologically and see if there's any damage to it. So the way we did this, we used 22 formalin embalmed cadavers. And we did have bilateral use of both the nerve and the muscle. So I classified the nerve as loose, tight, or embedded. Loose meaning this nerve wasn't covered in a significant amount of fascia attached to the muscle. And it could also be moved fairly easy with little force using forceps. Tight meaning there was a significant amount of fascia covering the nerve and it wasn't easily moved with forceps. And then embedded meaning the nerve was running through the muscle. So after that, we then measured the force needed to remove the nerve from the muscle. We used a digital force gauge, and I'll show that in a couple slides. And then while we were there, we also decided to take measurements of this muscle. So we took the diameter at the point where the nerve crossed the muscle, as well as the length from origin to insertion. Then our last step was to remove the obliquus capitis inferior muscle so we could visualize the nerve coming out between C1 and C2. And then we sampled it proximally, as well as at the point where it was crossing the muscle for histology. So here's a picture of the loose classification. So here's that C2 spinous process, and here's our muscle, and this is the greater occipital nerve. And this one doesn't have a lot of fascia attaching it to the muscle, and it could also be easily moved with forceps. As you can see over here on this one is very easily moved. It was pushed right off of the muscle. Here's our tight classification. So again, here's that C2 spinous process. Here's the muscle coming over, and here's our nerve. So this one has a lot of fascia attaching it to the muscle. So this one got a tight classification. Same thing over here. So here's that spinous process in the muscle. And here's the nerve very tightly attached to the muscle. And same thing down here. And then this was the last one. This one was really interesting. This was when the nerve was embedded through the muscle. So here's that C2 spinous process, and here's the muscles attaching out here at the transverse process. And here's our nerve running through the muscle. So you can see there's some fibers down here and up here. And then over here on this one, so this was taken after we started to reflect it to get a better picture. So here's where it was cut from the C2 process. And here's the nerve running into the muscle. And here's a little bit better picture. So again, we reflected it back from the C2 spinous process over here, and you can see the nerve diving in. So here's the outline of the muscle. This was how we measured the force. So this was our digital force gauge that we used. Unfortunately, I didn't think to take a picture of the process until afterwards, so that's why this one is so clean. But essentially, we just took this hook and we would pierce the fascia out here away from the nerve and slide it in. And then we'd get behind the nerve. And once we knew we had the nerve and not muscle, we would pull and we would see how much force it would take in kilograms to pull this nerve off of the muscle fascia. So the last thing we did was collect the nerves. So we took bilateral samples of all of the nerves except one. So the way we did this, we removed the obliquus capitis inferior. So here is our insertion site, or origin site, sorry, an insertion site over here. So we would remove this from the origin and reflect it back to where we can see the greater occipital nerve exiting between our C1 and C2 vertebrae. So what we did from there is we would take a sample proximally, and then we also took one more distally where it was interacting with the muscle. So at the point where we had that hook pulling it off. Our goal with this was to compare the most proximal site to the site where the muscle was crossing. We're going to look at the myelin sheaths and kind of get some measurements on that and look and compare the two to see if there's any difference. And we didn't take a distal sample because unfortunately not all of the nerves were long enough. Some of them kind of ended at the point where we were pulling them out, but they all had the most proximal portion. And this is what we ended up with. I did send off one sample just to make sure it would work and come out okay. So we had a semi-thin transverse section of the nerve done, stained with toluidine blue. And this is what that looks like. So what we're gonna do is look at all these myelin sheaths and kind of count them and measure them in certain sections and make sure, or just kind of compare the two most proximal in the portion with the muscle. So that should be interesting to find out here in a couple weeks. And so what did we actually find? So overall, we had 2 embedded nerves within the muscle. We had 21 tight nerves and 18 loose nerves. The average force to remove the nerve from the muscle on the left side was 2.06 kilograms, and the right was 2.13 kilograms. So there wasn't a huge difference there. The interesting part though, when we took the average for all of 21 of the tight nerves, we had 2.05 kilograms as the average force to remove the nerve from the muscle. When we took the average for all of the loose, we had 1.72 kilograms to remove the nerve from the muscle. So this I thought was interesting, and it kind of validated looking at our classification, the more objective one, kind of looking at that and having numbers to back up like, okay, yes, this was tight, this was loose. So that was an interesting finding. And then while we were there, we did take measurements of the obliquus capitis inferior. So the average diameter where the nerve was crossing the muscle was 9.81 on the left and 9.47 millimeters on the right. And length to origin to insertion was 55.07 millimeters on the left and 54.89 on the right. The last thing we did, we thought it would be interesting to compare the sexes and see if there was any difference, and we did not find a significant difference for the forces to remove the nerve in males and females. So a future direction for this study, future studies could include MRI or ultrasound evaluation of living patients with headaches to evaluate the tissues surrounding the nerve and the muscle. They could also involve an in-depth evaluation of differences in histopathology of the greater occipital nerve in cadavers. And it would be really great if there could be a more detailed medical history so we could see if these cadavers actually had headaches when they were alive. And differing attachment strengths to this muscle could be a potential culprit of these headaches. So I think it'd be really interesting if more research was done to evaluate this type of fascial attachment. Because like I said, there wasn't a lot of research out there. Some limitations to this study. We did have a good sample size, but unfortunately our sample size was a little bit too small to do any more advanced statistical analysis. Having a more complete medical records history would have been helpful as well. And I do wish we had a different tool to measure the force needed to remove the nerve. If it could have been smaller, it would have been a lot easier. And then lastly, I would like to acknowledge our donors as they made this possible for us and all of the students to learn on, as well as Dr. Tony Olinger and Sylvia Jeanette, a first year who helped me out on this study. And then the library services for helping me get all of the resources to help do this project, as well as Mizzou's One Health Biorepository for giving me the histology. Here's my references. Does anyone have any questions?
Awesome. Great presentation, student Dr. McBride. Well done. As she just said, if anyone has any questions, feel free to raise your hand in Zoom or unmute and just go for it. Or if you can't talk right now, you can also type it in the chat and I'll read it, make sure it's in the recording. Dr. Wolf, you have a question?
So I was curious here in terms of mechanism. So you indicated that stretching that nerve might be associated with some of the things that you're talking about here, like the headaches. And so I'm curious what kind of neurotransmitters you might think be involved in things like that. I mean, I'm assuming somatic muscle nerve, but are there co-transmitters in there or any other things that could be responsible for the pain sensation?
So what I read, a lot of the things I came across was looking at, there was like an oversensitization of the nerve, of different nerves, not just greater occipital nerve, but of nerves in particular with headaches and migraines. Really all that I came across in terms of like the neural pathways was that nucleus caudalis, the trigeminal nucleus caudalis, and the C2 proximity, I guess where those nerves travel, is kind of activating that trigeminal pathway. I'm not sure if that really answers your question, but that was the extent of what I came across when reading about nerves.
But it's like a retrograde transmission of some sort back to the origin, or I mean, so you're, again, I'm not an anatomist, but I'm assuming that if I'm twisting my head, that I'm contracting a somatic muscle, which has innervation that is efferent in nature. And so you're talking about either some retrograde transmission of efferent nerves or coexistent afferent nerves that are somehow returning that information back to the brain?
Possibly, I'm not honestly sure. So you're talking about the muscle, correct? Passing those signals back?
Well, I mean, if I guess in my mind, what I was thinking here, and perhaps I got everything wrong like I'm prone to do, but I was thinking, so you were talking about a whiplash injury causing damage. I thought you said like stretching of the nerve or something along those lines. And so if that nerve is in some way damaged, and that then is giving rise to the sensation of pain, which is in the central nervous system, there has to be some way of knowing that that is pain. So I was curious if you had thought about how that might be sensed by the body.
Okay, that's interesting. No, I hadn't thought about that. The only thing I really read up on, because I didn't understand how this nerve could cause pain and the sensation of like migraines, like up in this frontal lobe region when it innervates the scalp in the back. So really all I came across was that nucleus caudalis, and that was pretty much all I found. I didn't really look into anything deeper than that, but that's a really interesting question.
Well, like for migraines now, the new drugs are the CGRP, you know, so that whole pain processor, like the what's the word I'm looking for, the co-transmitters or whatever that some of these nerves have that might be involved in some of those sensations. Or the other thing, so I'm working on writing a manuscript right now, and the other thing, if you're not familiar with it, is this notion of exosomes. And so you have microRNAs, if you've heard of them, and so microRNAs are released in exosomes, and they trigger localized responses. So it's kind of a means of cells to cell communication where microRNAs made by one cell type can influence the responses of other cell types.
That's very cool.
Awesome. Any other questions, comments? If not, thank you so much, student Dr. McBride. Wonderful presentation. Great job. You're very articulate. Everything looked really good.
Thank you.